Hello, I'm Lynn Biot Gordon, and I'm the Chief Operations Officer and founder of the National and International Council of Certified Dementia Practitioners. And this is our presentation on intimacy and aging, issues and answers for long-term care. First, let's talk about the positive perceptions, the positive benefits that sexual expression can bring. First of all, sexual expression can provide tension release. It can abate loneliness, give a sense of belonging. It can lead to positive relationships. It can be mutually pleasurable. It can enhance one's self-esteem and enhance one's quality of life. The dilemma we have in long-term care, though, is a lack of training. Our frontline staff report receiving little or no training in their long-term care facility on the topic of sexual expression in the elderly. This means that facilities are leaving it up to staff to respond or react based on their own comfort level with intimacy and sexuality issues. Well, it's time for a change in attitude and a change in perspective. If our frontline staff have negative attitudes towards sexuality, it may be very difficult for them to assist others to maintain a positive attitude towards sexuality. If our own nurses and nurses' aides and other caregivers are not comfortable with this topic, they might feel that expression of sexuality by older adults is wrong, unnecessary, or even embarrassing. And this may lead to inappropriate interactions or even abuse toward a resident or client. So let's discuss what are the attitude barriers towards sex among the elderly. First of all, there is the stigma of old age, that sex is for the young, that old sex is disgusting, that old people aren't interested in sex. And then there's the double standard. Elder men are dignified and elder women are a turnoff. Other attitude barriers towards sexual expression among the elderly are religious views. Some feel that sex is just for reproduction. And what about our adult children's resistance? The child that says they couldn't possibly still be doing it. And then there's stereotypical roles from our society, like real men have erections. So let's look at the facts. Duke University completed a longitudinal study of 254 people ages 60 to 94. Part of their findings include this: 50% of 80-year-olds still have a moderate libido, 20% of 80-year-old men still were sexually active, 15% of all subjects reported increased libido, some even reported having late marriages, 30% of married couples over 75 years old were still sexually active, but overall there was a decline in libido as one ages. Sexuality is expressed by individuals of all ages in a variety of ways, including our clothing styles and the colors we wear, our hairstyles, hobbies and interests, and our sexual habits that continue into our older years, as well as gestures. Sexuality and sensuality may be expressed by sexual intercourse, caressing, touching, holding hands, masturbation. These expressions are basic rights of all residents to experience. Let's talk about practical issues. Ask your older patients about their sex lives. Believe me, they won't faint. Sexual histories are and should be a regular part of the overall client assessment. Some important considerations in sexuality for the older adult is medication side effects, stroke, COPD, diabetes, arthritis, and other illnesses, having a catheter, having experienced a prostatectomy, erectile dysfunction, sexual abuse, later marriages, dementia or other cognitive decline, LGBT concerns, and the lack of privacy in residential care. These are all very important considerations in our long-term care setting. There are also physical and psychological effects that must be considered, like removal of prostate or testes, amputation of a limb, removal of a uterus, removal of ovaries, removal of a breast, colostomy, or ileostomy. Let's look at a clinical example. Let's consider the elderly couple that's dealing with arthritis in their relationship. Some issues that might be considered are body image problems, making sure that the partner is gentle and patient, massaging and mutual masturbation, trying side-lying positions or coital positions for comfort to minimize pain, perhaps taking analgesics prior for comfort measures, And consider this, that sex in itself is an analgesic. There's other intimacy-specific advice that a practitioner could discuss with their client, such as the use of lubricants, hormone replacement, aids for erection, medications such as Viagra or Cialis and others, oxygen, also coping with messiness, which is also a reality of sexual expression, masturbation, or even the use of erotica, like magazines, videos, etc. Educating elders and families is key. What about the elderly and STDs and STIs and HIV and AIDS? HIV testing is usually performed under 3 circumstances. 1, as part of a targeted population survey. 2, in individuals with high risk, such as substance abuse, those with multiple sexual partners, and those with sexual contact with an HIV-infected individual. And number 3, in individuals with clinical presentations consistent with HIV infection. This strategy has actually been successful for the younger population that's at risk, but may miss the atypical presentations of the older at-risk population. Often, the clinical presentation of HIV infection in the elderly does not differ from that of younger adults, but symptoms of fatigue, anorexia, weight loss, and memory problems mimic other common geriatric problems. The characteristics of AIDS-defining opportunistic infections have similar prevalence rates regardless of age. The most frequent case of morbidity and mortality in older patients with HIV is bacterial pneumonia. There is an increased age-specific infection rate for varicella zoster virus, or chickenpox, in the elderly. And besides infection, the most significant cause of morbidity in elderly AIDS patients is neurological disease. It is often confused with Alzheimer's. It progresses more rapidly, over months, but it is compared to Alzheimer's disease. Older women are becoming infected with HIV at a higher rate than older men, and they may be particularly vulnerable to infection, not even realizing it. No longer afraid of becoming pregnant, they're in their postmenopausal years, and may be uninformed of the dangers of HIV transmission, and they might be more sexually active now in their elder years, maybe even having multiple partners. And they may have given up the decades-old habit of using condoms, while the elderly woman's biology increases her risk. For after menopause, the vaginal walls thin and vaginal lubrication decreases. Thus, the vaginal membranes are more likely to tear during intercourse, providing easier access for the virus. So education is the greatest intervention we can provide our elderly about the risks of HIV. Let's discuss education and interventions for our clients. It's important to educate them, in-service our clients on safe sex. It's important to in-service our clients, staff, and families on the topic of sexuality and intimacy in the elderly. Some facilities actually make condoms and other products available, even in their gift shop. And it's important that we encourage our clients to discuss their sexual health with their physician or other practitioners. We also need to provide culturally sensitive LGBT education in our facilities. The terms lesbian, gay, and bisexual are all different sexual orientations. Your sexual orientation describes your attraction to other people. Heterosexual or straight is also a sexual orientation. The term transgender describes gender identity. Transgender people's gender identity is different from the sex that they were assigned at birth. Gender identity describes the gender you feel you are on the inside. Staff also need to be trained to respond appropriately to sexual activity between people of the same sex, as well as best practices for transgender affirming care. One of the greatest resources that we recommend is that you go to the National Resource Center on LGBT Aging. But we do know that culturally sensitive education is very important in our facilities, and so far we know across the country it is lacking. Let's discuss sexual expression and dementia, addressing the caregiver concerns. What's inappropriate sexual expression because of dementia? Well, dementia can cause behaviors to be expressed publicly without regard of others, touching others sexually without being able to discern if the desire is mutual. And remember, pedophiles of yesterday are not documented. So in your facilities, we recommend a no-touch policy for non-family members for children visiting the facility. Inability to verbalize yes or no to other sexual advances is also related to dementia. Misinterpreting touches, smiles, and hugs as sexual invitations is also related to cognitive decline and lack of judgment. Engaging in sexual acts with someone who is not their spouse or companion, disrobing or urinating in inappropriate places, making sexual comments or gestures that might be offensive to others, fondling or masturbating in inappropriate places, or even unreasonable jealousy or suspiciousness of their partner. Sandra Day O'Connor is a retired U.S. Supreme Court Justice, and here's some food for thought from her. Her husband suffered with Alzheimer's disease for more than 17 years, and while living in an assisted living, they addressed a complicated ethical dimension in his disease process, where he took on a girlfriend. And Sandra Day O'Connor addressed the public this way. She said, "How enforceable is the lifelong contract of marriage for someone who doesn't remember the marriage?" So she was saying she was comfortable with her husband being comfortable in another relationship because she understood it was part of his disease process. So what are the interventions for other inappropriate behaviors due to dementia? Well, let's consider at the bedside. Raise the side rails up, step back from the bed. Use a calm and firm tone of voice if you're approached by the client. Call them by their surname to get their attention, therefore creating more of a formal boundary. And always identify yourself and your function or your intent. Don't scold them verbally. Do not use reprimanding body language. Do not ridicule them. And you may need to excuse yourself from the room. You may even need to change caregivers. Other interventions, for perhaps when something occurs in a public or common area. Discreetly remove them from the scene, assist them to their room, pull the privacy curtain or shut their door, provide whatever comfort items they might use during those times, and always maintain dignity, no teasing or shaming. What about inappropriate behaviors where dementia is involved and it's a couple engaging in relations? Allow privacy, keep families informed and involved in the care planning process. Observe for changes in non-sexual forms of intimacy between partners. Is he still sexually competent in spite of the dementia? Well, guess what? Having a diagnosis of dementia does not necessarily exclude you from having intimacy in your life. So if we're in a quandary about what's happening with a particular couple, we may need to make observations and refer to our ethics committee. And then also, we don't want to make assumptions about what we think are certain behaviors. Initially, we should observe for causes for particular behaviors. We may think that we're looking at fondling or masturbating, but it might be related to a urinary tract infection, a genital skin irritation or rash, or even uncomfortable clothing. We cannot jump to assumptions. Suggested interventions include wearing specialty clothing to minimize or actually keep us from disrobing in inappropriate places during inappropriate times, such as a fanny pack around a lady's waist, or even a decorative belt that is a distraction either for male or female, or athletic cup for our men, and even overalls with Velcro strips instead of buckles is considered an appropriate specialty clothing piece to keep us from disrobing or even dropping our clothes from the waistline. We might even utilize distractions such as snacks, photos, music, television. And we have to, as staff, model and encourage non-sexual forms of intimacy and be mindful of not leading to triggers to encourage inappropriate hand-holding, inappropriate hugs, or inappropriate dancing. And we may even offer suggestions or referrals as necessary for our well spouse or partner that might be having a challenging time with this topic. When should we intervene? When is a resident or client in an unsafe circumstance? Well, we need to bring our interdisciplinary team together. We need to meet. We need to define the nature of the problem, discuss the risks and benefits. Is the attention unwanted or uninvited? Does the patient understand the relationship and the consequences? Is the behavior consistent with previous values and behavior of that client? We've just talked about several topics related to sexual expression in the elderly. Now, let's address some common questions and answers. Question number 1. Don't older adults lose their sex drive and urges as they age? Well, the answer to that is this is a societal myth about aging. Sexual desires and energy may change over time. Even sexual preferences may change over time. However, as we always say, the libido dies when you die. How about this question? What is the best strategy to address sexuality with the resident and or the family? Well, facilities should have policies and procedures in place and be sure to open the dialogue from the beginning about what those policies are so that it's less uncomfortable and emotional if or when a situation arises. You might ask, how can I identify a LGBT-friendly long-term care facility for myself or my loved one? Some key things to look for are this. Does the facility allow same-sex or non-married couples to live together? Do they provide their staff training on LGBT issues? Do they help place transgender older adults with roommates? Does the facility display LGBT symbols or literature or include LGBT welcoming materials among their brochures? Do these agencies support families of choice in their policies and programs? Do they maintain a list of LGBT-friendly providers to whom they refer? These will give you the keys to knowing whether this is the right environment for you. What do we do when we're in the caregiving setting and a resident or client makes sexually provocative comments or gestures toward me? We must maintain dignity and respect toward the client at all times, using a calm and firm tone of voice, calling the client by their formal name to get their attention, while at the same time creating that formal boundary. Always identify yourself and your function or intent, never using reprimanding verbal or nonverbal communication, and you may need to excuse yourself from the room, and in some cases, we might need to even change the caregiver entirely. What do you do if you walk in on residents engaging in sexual activity? If they are consenting and competent, give them their privacy, or perhaps have a conversation at some point regarding safe sex practices. My nursing home roommate is verbally abusive because I'm transgender. Am I allowed to get a replacement? You do not have to tolerate abuse from either roommates or staff. Under the Federal Nursing Home Reform Act, a nursing home resident has the right to be free from physical or mental abuse and to prompt efforts by the facility to resolve grievances the resident may have, including those with respect to the behavior of other residents. The nursing home is also prohibited from forcibly isolating you from other residents. What happens if one individual has dementia and the other does not? When does staff intervene where sexual expression is concerned? The facility must have strong policies in place that are reviewed with residents, family, and staff. When dementia is involved, the facility should have a policy that includes informing the resident's primary contact person of observed sexual contact involving the resident. We must keep families informed. There's not always a clear-cut answer or approach. We must work with the family or responsible party to address the management of this moving forward. Clinical staff must assess for safety concerns to assure that the relationship is not abusive. What clearly needs to be understood is that dementia does not necessarily exclude someone from engaging in intimate relations. The divide occurs once a resident is no longer interested or unaware of the actions or circumstances they are being placed in. What gender roommate do you assign a transgender elder, and what bathroom do they use? You know, there's still a basic lack of understanding of how gender identity overrides biological sex, and that people should have room assignments and access to facilities that match their gender identity. This also leads to the facility's responsibility to assess roommate preferences for all residents, very much the same way we assess spiritual care, asking questions about prayer preferences, like does one like to pray in an individual setting or in a group setting? That's just an example. So we should be doing the same type of survey for residents, asking them about their preferences for a roommate. What do we do if two residents with dementia become intimate and they have a spouse or partner? The facility will have to follow the policy and procedures in place. Of course, as we mentioned previously, the facility's policy should be followed, informing the responsible party. We must approach the conversation with the spouse or partner with sensitivity, also reminding them that in no way does this relationship invalidate their partnership or their marriage. More so, what we are seeing is the disease process affecting one's memory, while the natural intrinsic need for love and companionship is still operating. Remember the words of Dr. Mary Calderon, who is a medical doctor and sex educator. She said, "Love is present even if one's memory is compromised." And we often suggest sharing with the spouse or partner the history of retired U.S. Supreme Court Justice Sandra Day O'Connor, who publicly shared her experience when her husband, who suffered from Alzheimer's disease, developed a new love relationship while living in an assisted living facility. Remember, she said she could not expect her husband to follow the contract of marriage when he no longer remembered the contract. Again, it is a very sensitive conversation, and staff should be supportive of the spouse and partner's feelings, as well as how they would like to approach the management of this relationship moving forward. Staff at a nursing facility are rude to a transgender resident and do not allow them to dress according to who they are. Are they allowed to do that? No. Under the Federal Nursing Home Reform Act, a nursing facility must protect and promote the rights of each resident. This protection includes the right of residents to a reasonable accommodation of individual needs and preferences. Facilities must also attain or maintain a resident's highest physical, mental, and psychosocial well-being. It's a nursing facility's job to ensure that you are treated with dignity and respect while in their care. As for your clothes, gender transition is now widely recognized by the medical community as benefiting a transgender person's psychological well-being, and one critical component is being able to live and be seen and treated by others in a manner consistent with one's gender identity. Thank you for watching this educational video. I'm Lynn Biot-Gordon, the Chief Operating Officer of the NCCDP and ICCDP. It is the intent of this video to provide education on the topic of sexual expression in the elderly for our staff, caregivers, clients, and other support personnel. While the subject of intimacy and aging is quite broad, our attempt is to address key concerns that those of us in elder care, especially memory care, face on a daily basis. Rajeen Moon from Training to Serve says it best. We're not here to change anyone's beliefs. We are there to help them give high-quality care to people who deserve dignity. Thank you. Here are some resources that we recommend.